So today we're going to talk about lever arms or levers in the body, because our muscles, our joints are our fulcrums, our bones are our levers, and muscles are our forces. How they interact, and what I mean by lever arm is the distance from the fulcrum to the force, and that effective lever arm decides how mechanically advantageous or disadvantageous our joints are when they move. Well, what happens with the human body, since it's not a 2D structure but a 3D structure, any rotation, any varus valgus, or any lack of range of motion will change the way the levers are functioning in the body and can cause what we call lever arm dysfunction. So today we're going to discuss that. We're going to discuss that for patients with spasticity, but also for specifically the patellofemoral disease and how lever arm dysfunction matters for that. So without further, let's go to the first slide. So my experience on this is twofold. The lever arm dysfunction or dynamic deformities is first popularized by Dr. Gage in Minnesota at Gillette Children's Hospital. And it's very known term in cerebral palsy literature. Our knowledge of this really comes from looking at deformities very closely and then analyzing them in our Gait lab, which we have a very sophisticated Gait lab, looking at the rotational abnormalities and combination of varus valgus or flexion extension deformities. So we are, of course, looking at only lower extremities for this, and they are weight-bearing joints, and that's what we are going to talk about today. So one of the most important things when you talk about lever arm dysfunction is to always measure. We always measure well the varus valgus flexion extension, but we must also measure rotational profile very closely. And it is done in a prone position, while as you stabilize the pelvis with one hand of the examiner, and then you go to the end ranges. And of course, here is the external rotation. It's going towards the body, but it's external rotation because patient is in prone. Here is your internal rotation of the right leg. And then you look at a thigh foot axis angle, which is basically an angle measured from the foot, a line that draws from the center of the heel to the second metatarsal head in relation to the femur. Some people measure bimalleolar axis as relation to thigh. Some people measure thigh foot axis, but the idea is to look at the component of rotation that is between the knee axis, ankle and foot axis is what you're trying to measure. You have to measure this with subtalar neutral, otherwise you get a wrong measure because foot tends to go into more valgus in this position. And then you can also measure interrotation like this, where you are automatically stabilizing your pelvis. So careful rotational measurement in addition to varus valgus and flexion extension measurements are very critical to document that. So what are levers? We have three types of levers in our human body. So this is a lever one, type 1 lever, where you have a fulcrum in the center, and then you have body weight dropping, and you have abductor force or abductor mechanism force like this. And this force counterbalances the body weight. Now, because the distance of the body weight is about 2 times the distance from the abductor lever or abductor force, you have to produce 2 times the body weight force in the muscles or structure around it. So that's a type 1 lever. The type 2 lever is more in the ankle joint, where the load is in the center going to the talus. Your force for plantar flexion is coming through triceps surae or gastrocnemius soleus, tendoachilles, and your fulcrum is here. So it's not as advantageous. And the last one is the most disadvantageous lever, but it also keeps our body slender. That the force, the fulcrum is back here, and the force from the biceps is coming very close, but our load arm is far further away. So the biceps has to produce more force than one can imagine, but it keeps our body slender. If the biceps was here, our body would be very bulky, and we would have mechanical advantage, but we would also have a body that looked much different. So many of our levers basically are type 2 levers in our human body. So small changes make big differences in the lever arm or the lever arm distance, which is the distance from the fulcrum to the force vector, is the important concept here. Well, we have certain inbuilt mechanisms in our human body that allow us to maintain the forces by having the joint glide. This is a beautiful example of the lever arm of the gastrocnemius soleus muscle. And then once you go into plantar flexion, you have a glide that allows you to increase your lever arm, thus maintaining the force of the gastrocnemius muscle. So joint glides are very critical. Getting muscle strength back and not just range of motion back is a very important concept for physical therapists to remember, is that if you have a joint glide, you will get mechanical advantage and strength gains in your ankle complex. The opposite of that happens with the knee. When the knee is flexed, the lever arm distance actually increases. So you have, though the hamstrings are shortening, they have a mechanical advantage and a significant mechanical disadvantage for your quadricep muscle as you go into more and more crouch. And this was actually very popularized by Dr. Gage from Minnesota. The other factor that we have to remember is when we walk, we have to have certain degree of foot progression angle, which is 7 to 12 degrees external, in order to keep our knee axis parallel to the ground and perpendicular to the line of forces. So imagine if your foot is too far out and your knee axis is turned out also, you would have the foot touch the other leg as you are going into knee flexion during swing phase. And if your femur is turned in where your knee axis is actually internal, then you would have a valgus, apparent valgus. And you see this in runners, especially if they have internal femoral torsion. From the back, you will see them legs go outwards and they look splayed. We call it splayed legs because it looks like as if they have valgus, but it's not a valgus. It's just the rotation of the knee that's occurring. Normally, we have shown this slide before to you. Normally, we stand like this, and our force vector is, our mechanical axis is well aligned for hip, knee, and ankle, and our weight-bearing axis in the center. But when we stand at attention, our legs turn in a little bit, putting some stress on the abductor mechanism, giving us mechanical advantage. I would like to focus this slide a little bit on because this is an important slide about lever arms. So if you look at the way we are in single stance, the ground reaction force vector is about going through the medial collateral ligament. So it's producing an adductor or a compressive force on the medial compartment. The ground reaction force vector is slightly lateral, so it's producing a slight abduction component on the ankle joint. So that's an abduction moment with a moment around the ankle and foot joint. And of course, in the hip, it's further medial to the hip joint center. So it's always trying to produce an adduction or a varus moment around the hip that is counterbalanced by muscles that connect from ilium to the trochanter and below, including the fascia lata, abductor muscles such as gluteus medius minimus and tensor fascia. So those are the important concepts. Now, look at this. This is the lever arm distance for the ground reaction force vector. So if you have a deformity in varus, you will increase this lever arm distance and thus increase the force on the medial compartment, which is the genesis of medial compartment osteoarthritis. In the sagittal plane, we have our lever arms are much more mobile, meaning they move as the body moves forward. The knee joint, hip joint, and ankle joint are subjected to ground reaction force vector in sagittal plane that is continuously moving. And that is why it's so critical that we have sagittal plane control significantly through the muscle coordinated activity of the muscles, like quadriceps, deceleration through hip extensors, deceleration through eccentric unloading of the tibialis anterior, and the propulsion finally through gastrocnemius soleus. So all those becomes very important coordinated activity of the muscles to balance against the abnormal forces and the moments that are around. This is a classic example of changing the lever arm distance. So here is lever arm up to this much. And by shifting the body weight over, we can reduce our lever arm distance, thus reducing the demand on the abductor muscle. And that's a better example of that, where you can see here the lever arm distance has now decreased by leaning the body towards the right side, and thus you can reduce the load that is needed for the abductor muscle. And this is a more a clinical example of the same thing, which shows by changing the weight shifting a little bit, you can actually reduce the amount of effort that the abductor mechanism has to do. So it's a nice example of that in the literature shown. This is another lever arm dysfunction. It's not truly a lever arm dysfunction. This is a patient with rickets with various deformities, but I'm focused more on his trunk. His trunk is going from left to right, as you can see significantly. And this was very nicely highlighted in a paper by Dr. Vasudev from Kerala in British Bone and Joint Surgery Journal that actually showed that this is a lever dysfunction, because you're by doing a varus of the knee is also equal to abduction of the femur. So when you have abducted femur, you have a reduced forearm lever, and thus you have a abductor insufficiency, and you're not able to balance your body weight over your supporting leg. This is an abnormal lever arm created by models. And what I mean by that is, here is the stance phase on the left side of this model, and it shows that she is in significant adduction, because if you look at her pelvis and then look at her adduction of the femur, it's significant. It's a lot more than so what she is doing is intentionally dysfunctioning her abductor mechanism to a point that it cannot be supported, and thus the pelvis drops. And then the same action is taken on the wrist side when the right side is in the stance, thus making the pelvis drop on each side and causing that runway walk that we talk about. But it's really dysfunctioning your own abductor mechanism to do what you're doing in this. Well, in medicine, it's exactly the same. This is a patient who, and I'm going to slow down this video so you can focus on this a little bit better. If you really carefully look at this, as she lands on her left side, and as there is weight acceptance of her left, her right pelvis is dropping significantly. So she has to be quick to lift it, put it back down, and then again the same thing happens. And this is the significant hip problem. And we have even given you the musculographics model that shows it even better in terms of the drop of the pelvis in each stance phase. So right stance is now in the right stance. As soon as she weights bear, she goes down. She goes down. So there's a continuous drop of the pelvis, and she is not producing any abductor movement in her abductors as she walks, because she is dysfunctional. Why is she dysfunctional? Because her femur is in interrotation significantly. So she has two problems. She has a coxa valga, and she has a femoral interrotation deformity significant. So if you look at a normal relationship of how the lever arm is, when normal walking is there, this is your trochanter. This is looking from the top view, and you can see here that the normal lever arm is distance X, and your full line of progression is forward like that. But when you have significant interrotation, patients have no choice to try to attempt to externally rotate as much as they can. Well, doing that, they reduce their lever arm. So their abductor mechanism becomes significantly dysfunctional. On top of that, some of these patients have coxa vara. So both these together cause this deformity. And in order to correct that, there are few more dynamic components of that we will talk about in a second in cerebral palsy. But this is one of the static components of lever arm dysfunction that causes such abnormal gait. And it can be very well corrected with careful surgery in use of strategic use of botulinum toxin and physical therapy. And that this is an example of that we will show you in a second. And if you look at this girl now, after we did the bilateral derotation osteotomies, Botox injection for spasticity management in certain muscles, which we'll talk about in a second, and she's not dropping her pelvis as much. She's actually grown. She's put on more weight, but her abductors are able to hold her with the strategic surgery that was done to correct her gait, which is she's not dropping, she's sure of her gait. She's not perfect. Cerebral palsy patients can't be made perfect. They can be made better. So we have made her better, I think, and her gait is more sure. And we have long-term follow-up on some of these children, and they seem to do well with this. And I will highlight the dynamic components of this in a second, so bear with me on that. So once again, this is the abnormal lever arm of the ground reaction force vector. As you get more varus, you get more forces on the medial compartment. We talked about that. And one of the strategies that one can use to reduce the lever arm dysfunction is what we call toe-out gait. This was actually shown very nicely by Dr. Andriaki, where all you're doing is by toeing out in the 3D plane, when you toe out, you reduce the lever arm of the ground reaction force vector. So just by toeing out your foot, now you can't toe out so much that you just can't walk properly. So you have to toe out within 10 to 15 degrees. But even with that, you are able to reduce the moment arm and reduce pain or compressive pain in the medial compartment, has been shown by Dr. Andriaki from Stanford University, but also other people have reported on this, and that's a very important concept. Well, what happens if you have a varus deformity of the knee, but also have internal rotation? You cannot external rotate of the tibia bone. Well, you actually have increase in the forces, even if with no varus deformity, just by having internal rotation or toeing in gait, you can have increase in adduction moment. So when we look at the patient, we always say that if you have a varus, but you have external rotation, you will not have malalignment, but you have other problems, and I'm going to talk to you about that. But if you have external rotation, that's therapeutic. And that's something that we can use as therapists clinically for gait retraining, or we call it normalizing a movement strategy or changing the movement strategy, which are all the things that are useful for therapists to know. So what we have seen, the effect of malrotation on the knee is that femoral internal rotation and tibial external rotation produces a valgus moment on the knee, meaning that it's abducting the knee joint, while as femoral external rotation with tibial internal rotation causes a more varus force on the knee or adduction force on the knee. And there are many components that are causing femoral internal rotation. Some of them are static, we talked about that, but there are many dynamic components, and that's where the therapy is so useful and important to address those. And there are some dynamic components or tibialis posterior, tibial external rotation also, and we'll talk about that. This is an example of a hemiparetic patient who does not have a varus or a valgus deformity. He looks like he has a valgus on the left knee. But look at it carefully. If you look at his forces, normally the forces are in adduction plane, but he's got valgus or abduction force on his knee, and because he has femoral internal rotation and tibial external rotation. So it is equaling out, so his foot progression is still okay, but he has a dynamic and a static deformity in his tibia and his femur bone. That results in an abnormal valgus moment, while as normal is a varus moment on the knee. Over long term, this is a problem, and this can cause severe osteoarthritis by age 35 in patients that are neglected with inappropriate management. We have seen the opposite of that. This is a patient with SCFE, or slip capital femoral epiphysis. And what we have seen in this patient is he has an external rotation of the femur. You can see the markers are more out like this. So he has external rotation of the femur bone, and he has a varus and an internal rotation of the tibia bone. So, and you can see here his typhoid axis is internal on the left side and neutral to slightly external on the right side. So we are focused on the left side now, and you can see even in the Gait lab, he has significant varus or increased varus forces on his knee, and he has a hip that is externally rotated, and the tibia or the knee, we call it knee, but tibia is internally rotated, progressively increases. So overall, he has also a varus. So it's a bad combination of having external rotation. So think of all your osteoarthritic patients that tend to rotate out, and if they are tight in their rotators, that is something that we should look at carefully as therapists to normalize that tone of those muscles and get patients to have a better movement strategy while walking to reduce forces on the knee joint. This is the opposite example of the other guy that I showed you. This is a patient with a significant internal rotation of the femurs. And external rotation is of the tibia. The right is not as bad, but the left is definitely off. So this is a skeletal abnormality, but not all skeletal patients, deformity patients, require surgery. There are many patients with proper muscle training and control, and several things that we can talk about as a separate lecture. You can actually reduce the dynamic component of this enough for them to have a normal, happy life. So, so this external rotation in combination of increased internal rotation causes a problem in her gait. Now I want you to focus on her left side. And if you see her carefully on the left, how she buckles into what looks like a valgus, but it's not. It's a combination of internal rotation of the femur and external rotation of the tibia. Well, what's the result of that? She has a MPFL strain, medial patellofemoral ligament strain. Every time she walks, she's stretching that medial patellofemoral ligament component. And some of this is habitual. Young girls tend to do that. So we have to rule that out first. We have to rule out some of the muscles that I'm going to talk to in a second. You have to look at her skeletal alignment, which is shown here. And many of these patients I have treated for knee pain or having knee problems, but the problems are also dynamic as well as some static. And when the dynamic components alone are not enough to solve the problem, that's when patients may need derotation osteotomies to make them better. So what happens with that is that very small amount of rotation changes the compressive load of the patellofemoral joint, and any internal rotation causes significant point loading in the lateral trochlea, and thus causes early arthritis, chondromalacia type pain. And if we can control that, most of these patients can be resolved. They have to do some lifetime exercises, which we'll talk about in a second. And then we have to teach them the correct strategy of movement. And this is a correct strategy of movement that we will encourage them to do by keeping the femur in external rotation and helping them do the movements correctly. Because remember, step down loading is significant than step up loading even on the patellofemoral joint. So we will do that. So these are the dynamic causes of malrotation. These are all already published in the literature. So a combination of hip flexor and adductor tightness will lead to femur being internally rotated. And this has been reported by Scott Delp from Chicago, I think, where he actually showed this in both patients as well as in the models, that if you take a patient and just make the hip flexor tight and adductor tightness, the femur will internally rotate and function as an internal rotation deformity. Medial hamstring tightness or spasticity has been shown to be also rotating internally the femur bone. This is the best evidence right now in gluteus medius and minimus weakness, with collegiate athletes having patellofemoral pain resolved with proper training of the gluteus medius and minimus, with correcting the movement strategy as well as strengthening the muscle, has been already shown. TFL, is an internal rotator, so that can cause problems. And then the pronated foot or a flexible flat foot or a peroneal spasm has been shown to change or alter the way tibia is functioning in walking. So all of these dynamic factors have to be considered before one treats a patient with knee pain, especially patellofemoral pain, especially younger patient complaining of knee pain. We have to rule these out. So a comprehensive biomechanical evaluation is needed for measuring these and to address this in long run, in my opinion. I wrote a book chapter in Orthopedic Clinics of North America. I'm very happy that I did it. And the title of that chapter is What is a Quality Therapy or Quality Therapy Before You Decide to Do Surgery? So, what are those components of quality therapy that will make change in patient's life? And basically, we looked at patellofemoral dysfunction and static and dynamic components of patellofemoral dysfunction. So you know the skeletal default, the tightness contraction is important. So patellar tendon tightness, quadricep tendon tightness, lateral retinaculum tightness, you can measure all of these or assess them. IT band tightness, hamstring and gastrocnemius tightness, rectus femoris iliopsoas and epiductus. So you have to rule out these tightnesses or contractures. The skeletal, you know, abnormal slope or trochlear, trochlear dysplasia, malrotated trochlea, genu valgus, femoral tibial malrotation. Some people even call it horrible malalignment or malrotation because the femur is internal, tibia is external, the foot is neutral, but you have tremendous impact on your patellofemoral as well as on your knee joint. Knee flexion deformity and flat foot or planovalgus foot, which rotates the tibia out. Then you have muscle weakness or laxity problems, VMO laxity, gluteus medius weakness, hip flexor tightness, hip external rotator tightness, MPFL or LPFL laxity, and abnormal VMO VL control, and then the systemic causes. This chapter has been reviewed, I'm very proud to say that has been reviewed in more grand rounds than any other grand rounds for patellofemoral disease. That's very interesting, especially in the rehab literature, in the rehab world, physical medicine and rehab world, not so much in orthopedics. So it's a nice recognition for this. And if you get ever a chance to read it, it's available on internet. It is in Orthopedic Clinics of North America. And I was very happy to do that. So those are the dynamic components of managing it. So I don't just, I always like to show slides of what I have done, and I probably have shown this slide before, but I'll show again. This is the case. It's the bilateral patellofemoral subluxation and pain. You can see with her skyline views, she's so much into loading her almost lateral edge of the lateral femoral condyles on both sides, trochleas, and she has point loading of the lateral facet on both sides, subluxation about 40% here, 50% here. So the traditional treatment for this is always lateral release, lateral retinacular release, with sometimes maybe augmentation of VMO, arthroscopic surgery, and this is done in many, many cases. And she was considering that, and then I offered her a solution or a treatment after her orthopedic surgeon referred to me because she was an active runner. So what was the patient? The patient has 1 year history of pain in long distance running. She's a 44-year-old female, 127 pounds or 55 kilograms, 5'3", 5'3" tall, used to run up to 30 miles per week, did 7 marathons before, no running for a year due to patellofemoral pain. So there are the problems. And I showed you these small rotational changes. So what did she have? She had a tight IT band. She had a VMO, VLO abnormal ratio, in my opinion. She had significant hip abductor weakness. And now you could say that it came from inactivity for 1 year. It's possible. Increased interrotation, both hips, and both legs were symptomatic. She had some pes planus, but it was flexible, meaning that when she go up on her toes, she was able to create arches. So I wasn't sure if I should give her orthotics. Abnormal movement strategy for step down, step up, and lunge, and a slight right knee flexion contraction and right hip tightness. So multiple problems. So this was my initial evaluation, biomechanical evaluation of this patient. So what did I do? I did 8 sessions of treatment. I was very aggressive in soft tissue mobilization. We use a tool-based soft tissue mobilization technique where we did that, especially focusing on the distal IT band and the slip of the IT band that goes to the lateral retinaculum so that the patella is not pulled superiorly and laterally. That was important. Patellar mobilization, aggressively going from lateral to medial and superior to inferior. NMES and quad strengthening, and NMES for the vastus medialis, 1 electrode on the medialis obliquus. A manual therapy for stretching for the IT band, hip flexors, and lateral retinaculum. I talked about it. We did some kinesiotaping for facilitation, hip strengthening, And then we followed a Scott dye method where Scott dye is, we call it tissue homeostasis. The exercise that we did has to be never be painful. And we worked within the envelope of pain. And we did this, I think, 1 or 2 times a week for a few weeks. We did it for a long time. And this is an example, and this is what we did. So if you look at the pre-op of her leg, you can see she's almost lifted on her medial side, very weak vastus medialis, and it's detensioned and tightness here, and a position of subluxation bilaterally. And these are her x-rays afterwards. It's almost like surgery. So we were able to, so it's not always just surgery. She has interrotation, and she has some of the structural components we talked about, but she also had significant dynamic components. And we can help patients a lot as therapists if we assess the patient biomechanically correctly. And I'm proud to say that I now have 8-year follow-up on her. And she has only come once after that for a week, what we call a tune-up. And she continues to be active. She's older now, so she's not running marathons. She's doing more elliptical bikes and doing short runs and some pool therapy just for aquatics. But she's still very active. So we saved her from surgery, but more importantly, we kept her active for 8 years with strategic treatment of her patellofemoral joint. So I want to emphasize that not all skeletal deformities are untreatable. We can't change the bone, but we can change the structures around the bone, how they function dynamically as well as statically, meaning what contractures we have and how they are functioning in terms of movement strategy. And more work needs to be done on this, because I think majority of the younger patients that report to you with knee pain actually are not tibiofemoral joint pain, but patellofemoral joint pain. And it's neural, it's more neural or more sensitive area. And that's been shown that patellofemoral area, especially the extensor mechanism and structures around it, are very sensitive. They are innervated very well, and thus they can produce pain very quickly with inflammation or with abnormal alignment. So that's the take-home message here from this slide, is that that is what we should be striving for as therapists, to identify the structures that are causing the problem and treat them aggressively enough to produce. So I always talk about this, that joint has to have correct arthrokinematics. We have to produce that by neutralizing the tension around the soft tissues, if we can. If we cannot, it's a surgical case. I agree with you totally. But if we can change the arthrokinematics of the joint and have normal movement, because our cartilage loves normal movement. It likes loading. It doesn't dislike loading, but it likes loading in the correct arthrokinematic plane. So that's what we should strive for in all our patients. And this is something about the foot. When the foot is externally rotated, there's also some planovalgus component that is addressed because of the change in lever arm. And this is the foot example of that. And that's a very interesting topic by itself. If you look at the foot and what happens to the foot, is we have seen this, and you will see this in idiopathic toe walker. You will see it in patients with cerebral palsy, with stroke. What you see is a breakdown of the lever arm of the talonavicular joint. So there's a navicular drop when you have a force that is right here, and the contact is here. So you have a breakdown of the lever arm right here. So what you have is lax in children, especially. You see this more often, where if you don't neutralize the tone and brace them appropriately, release them, stretch them, whatever it is, then you will start seeing a talonavicular breakdown. And breakdown, we call it a rocker bottom foot, because the arch that's supposed to form is now flattening down. You also see the effect of valgus on the toes. Hallux valgus is very common. Some people think that women wearing high-heeled shoes and getting bunions is similar to what we see here, is that that's the primary cause, but it's not been fully proven. But it's a very interesting idea that a narrow toe box with a valgus force, because you're an equinus when you wear a very high-heeled shoe, can cause the same type of effect on the foot. And then the result, the end result, if you see this slide here, the foot is totally collapsed. And this is an older child, so he's been walking with a with a tight gastrocsoleus component. He has a mild spasticity, and then basically you have a foot collapse. And now this is require a major reconstructive procedure to get the ankle joint to function like it should, because now the ankle joint is in significant planovalgus, and a broken down lever arm is broken down here in terms of foot. So we have to always think of this as a static and a dynamic component of levers, and how the levers are functioning, and try to address the soft tissue component of it. And when I say soft tissue component, it could be the solution could be bracing, it could be orthotics, it could be not just physical therapy, but we have to always think of things that we can do. Not I have a therapist that I know for last 20 years now. I hired her when I was we just moved here to Rubin Institute. She has 90 degrees of internal rotation and only 15 degrees of external rotation in her hip with slight coxa valga. She's very active. She has run 3 marathons. She stretches her hip because she has tight hip flexors. She has weak abductors. She strengthens her abductors. But she's fine. She's not, any other patient would have problems. She has had knee problems. We have treated her before with ASTIM or soft tissue mobilization, sometimes taping, sometimes dry needling nowadays. But in the end, we have kept her going because half the battle is managing the abnormal movement strategy, strengthening the appropriate muscle, stretching the appropriate muscle or joints, and maintaining that arthrokinematics of the joint in a correct plane. The last patient I want to show you is that not all deformities are structural. Because if you look at this, the guy stands with significant internal rotation. But if you really examine him carefully, he has slight increased internal rotation, but he has abundant external rotation. So his neutral axis is not internally rotated. As you can see here, he has internal rotation, and he has external rotation. So his neutral for the internal external is here, would be somewhere in between. So he does not have that as a problem. And typically, thigh foot axis, I think I don't have a picture of that, but that's normal. But look at how he's walking. Look up now, and you can see, because what he has, and he's not, how should I say this? This is not reproducible. There's a variation in his internal rotation of the foot. But what he has is, there is some spasticity and tightness of the tibialis posterior, tibialis anterior, and medial hamstrings and adductors. All of that, so he has a mild tone. He's not a CP. We don't know if he's truly CP, but he responded really well to normalizing his movement strategy, stretching by parents at home. We actually used a bracing for a while, and then he needed 1 or 2 Botox injections, and he did well. Now he can force it to walk with his foot slightly forward, as you can see it at the last. So this is a different variation. So the abnormal muscle tone and spasticity, because it's always on, but also abnormal muscle tone and weakness can cause the problems that we have discussed. So basically what I tried to do in summary is to give you a flavor of what the biomechanics of the lower limb can be. Now these are each topics of, just one topic of malrotation is a lecture by itself in terms of how to do therapy or how to manage these patients in case examples, and we can hopefully do it one day. But I just wanted to give you a flavor of how the thought process should be in the next century. I'm telling you this, that not every patient should have surgery, not every patient needs surgery, and we have to, as therapists, think outside the box as to what can we do to change the outcome of our patients who come with they need help, and how are we going to change it? Now, I don't mean to say that you should do everything on every patient. You be strategic. You try a few things, but you try things that will work in your hand, and you do them. But you don't want to refer every patient for surgery. I can't help you. That's the only thing that I want to send as a take-home message. So I will stop here, and I will take any questions if you have any. If not, I have a patient waiting outside that I can go to. 10 degrees of internal rotation of the femur will increase the patellofemoral lateral facet force by almost 50%.
Yes.
At 20 degrees will lead to 100%
Wow.
increase in load.
Yeah.
So you're putting now 2 times the force that you're supposed to. And if you use your quadricep muscle, like I showed on
Hmm.
last webinar,
Mm-hmm.
if you contract your quadriceps with knee flexion, which is what you're doing with stair ascent or descent, mainly descent more vigorous,
Hmm.
you're putting already 6 times body weight forces.
Yes.
Okay, 5 to 6 times on the
Yes.
patellofemoral joint. Now
Right.
you're putting double of that. So now you're putting 12 to 15 times body weight force on a very small area. Imagine what would happen to that cartilage, and
Even
you do
this,
that multiple
even the
times.
step down strategy that you told us about. I
Yeah.
mean, I see that so often in our patellofemoral patients. The step down strategy with where they employ a little valgus instead of varus. I mean,
If you're
taking the.
interested in more about this, there's a paper that is on collegiate athletes with patellofemoral pain. They looked at 35 female athletes,
Hmm.
mainly females. This is seen in more in females. And they looked at their abductor strength, and then they put them on a specific program of stretching and strengthening. And they were able to resolve 80% of the patellofemoral pain that led the athletes not to function.
Wow.
The paper on that. So there's value, and I'm sure my literature search for this has not been as current as it should be, but these are when I was doing more research on this topic. But there's also new literature. This is very supported by literature in terms of the abductor weakness and its causative effect on the knee pain, especially patellofemoral pain. So I truly believe in that in terms of how you manage your hip matters in how your knee functions. And I always say that if you don't examine, you don't know.
Right.
If you take an attitude that you have patellofemoral pain with inflammation and let's put some laser on it, and that's okay for temporarily managing inflammation, but that will not solve the patient's problem for 5 years